Great, thank you. I need to be a little taller here. I'd like to thank Dr. Friedman for the invitation to participate in today's panel. And my task is to discuss the role of radiotherapy to the supraclavicular and axillary nodes. I would argue that regional nodal irradiation is playing an increasingly important role in the management of patients with node-positive disease. And I'm actually married to a breast surgeon, and he agrees with me on this statement. We all recognize that there is benefit in patients at high risk of local regional recurrence, but there's a lot more controversy in patients at intermediate risk of local recurrence, that is, those with 1 to 3 involved nodes. And this explains why these patients were actually included in the NSABP B39 RTOG 1304 randomized trial of whole breast irradiation versus partial breast irradiation, because at the time of the design of that trial, it was not thought that these patients needed nodal irradiation. But all of that was in an era of axillary lymph node dissection, and we're now moving into an era of sentinel lymph node biopsy, which is replacing the more morbid axillary surgery, certainly in node-negative patients, and as you just heard, increasingly for some node-positive patients as well. There have been 5 recently published randomized trials that have really changed our management of the nodes. The International Breast Cancer Study Group 2301 and the ACOSOG Z11 trial, which you just heard about, asked an important question as to whether or not patients with an involved sentinel lymph node needed to go on to a completion axillary node dissection, which was the standard for many years. The IBCSG trial had a very similar design to the Z11, but it restricted inclusion to patients with micrometastatic disease in the sentinel lymph node, defined as 0.2 to 2 millimeters, so very low burden of disease. These patients were randomized to a completion axillary node dissection or no further surgery. The radiotherapy was not pre-specified in this protocol, and 9% of patients actually had a mastectomy without radiotherapy. Of the patients who underwent breast-conserving surgery, 19% received IORT alone, which didn't address any lymphatic regions, and 79% received some form of postoperative radiotherapy, but the details of those plans are not available. At a median follow-up of 5 years, there was no difference in disease-free or overall survival, suggesting that patients with micrometastatic disease in the sentinel lymph node may be able to avoid a completion axillary node dissection. You already heard about the Z11 trial, which enrolled patients with no more than 2 involved sentinel lymph nodes and randomized them to completion node dissection or no further surgery. Now, patients, as you heard, were supposed to receive whole breast radiotherapy with no specific targeting of the axilla. And you saw these curves already as well, that at median follow-up a little over 6 years, there was no difference in disease-free or overall survival. And this really changed practice patterns because everyone's very eager to get away from an axillary node dissection, but there's still a lot of questions about the radiotherapy. Dr. Jagsy and colleagues attempted to obtain the radiotherapy records for patients enrolled in this trial, and of the patients they were able to review, they noted that 81% received tangents only, while 19% actually received directed regional nodal irradiation. And of the patients who received tangents, about half of those were deemed to be high tangents. That is, the superior border of the field was increased in order to encompass more of the level 1 and level 2 axilla. There was no difference between the treatment arms with respect to the radiotherapy fields, and we don't necessarily know how this might have impacted outcomes, but it highlights the variability in treatment approaches for these patients. The AMAROS trial asked a similar but slightly different question as to whether or not patients with an involved sentinel lymph node should receive an axillary node dissection or could be adequately treated with targeted radiotherapy to the axilla, including all 3 levels of the axilla and the medial supraclavicular region. At a median follow-up of a little over 6 years, there was no difference in disease-free or overall survival, and the authors concluded that these patients may be adequately treated with axillary radiotherapy in lieu of an axillary node dissection. So how do we understand all of these different trials? I think it's important to also look at the number of involved nodes. You can see that the IBCSG was a very favorable population, not only because they all had micrometastatic disease, but because 95% of the patients had only 1 involved node. In contrast, there were many more patients in the Z11 and AMAROS trials that had 2 or even 3 involved nodes. And what's also interesting is the AMAROS included some patients with isolated tumor cells. So that's defined as less than 0.2 millimeters. And Some might argue that these patients didn't need axillary node dissection, but they might not have needed complete axillary radiotherapy either. So we can conclude from the IBCSG, the Z11, and the AMAROS trials that axillary lymph node dissection can be safely omitted in patients with involved sentinel lymph nodes, and it substantially decreases morbidity. When thinking about, though, how we design our radiation fields, I think it's important to think about the size of the metastasis as well as the number of involved nodes. But what about patients who've received an axillary node dissection? The MA20 randomized patients with node-positive or high-risk node-negative tumors after axillary node dissection to whole breast irradiation or whole breast irradiation plus regional nodal irradiation, which included the internal mammary nodes and the medial supraclavicular fossa. You all are familiar with this publication in the New England Journal of Medicine just from last year, which demonstrated a statistically significant improvement in disease-free survival, local regional disease-free survival, and distant disease-free survival. They did not reach statistical significance for their primary endpoint of overall survival, but there was a trend in favor of the regional nodal irradiation group. And a pre-specified subset analysis of ER-negative tumors showed that they had the greatest benefit and an improvement in overall survival that neared statistical significance. Of course, we all expected improvements in local regional disease, but what was most striking is the greater impact that regional nodal irradiation had on distant recurrence, suggesting that while a local recurrence may be a nidus for metastatic spread, there actually may be some occult nodal disease that has distant metastatic potential, even without a local recurrence, that our treatments may be affecting. The EORTC 22922 trial was of similar design, randomizing patients to breast or chest wall radiotherapy with or without regional nodal irradiation, including the IMNs and the supraclavicular fossa. And in that same journal issue, they reported a statistically significant improvement in distant disease-free survival and breast cancer mortality, with a trend towards improvement in survival in those who received regional nodal irradiation. But when we're thinking about our radiotherapy treatment plans, I think it's important to look at the size of the metastasis, the number of involved nodes, and the number of lymph nodes resected. Other factors such as LVSI or young age might also influence us. And the biology of breast cancer is, of course, increasingly being noted as a predictor for local recurrence. But I also want to talk about changes in systemic therapy. Trastuzumab was approved in 2005 for the adjuvant treatment of HER2-positive breast cancer. So this was after enrollment, accrual rather, of the EORTC, and only at the end of accrual for the MA20 trial. So I think it's unclear what improvements in systemic therapy, particularly in this population, whether that'll impact our benefit from any benefit from radiation. We're also seeing extended endocrine therapy, so patients used to get 5 years of endocrine therapy, now they're getting 10 years of endocrine therapy, so that may also push back recurrences even further. And there are also changes in the use of chemotherapy. For example, the responder trial is randomizing patients with ER-positive, node-positive disease with a low or intermediate oncotype recurrence score to chemotherapy plus endocrine therapy or endocrine therapy alone. That trial has closed and has not yet been reported, but I've already seen in my practice that medical oncologists and patients are backing away from cytotoxic therapy, even in the node-positive setting. And of course, whenever we're thinking about treatment recommendations, we have to discuss risk, and we saw that there was a slight increased risk of lymphedema and pneumonitis in the patients treated with nodal irradiation in the MA20 and EORTC trials. And finally, I think biological factors will be important to help us understand and determine which nodal mets might actually have distant metastatic potential and might gain the greatest benefit from our treatments. So in summary, if there's low risk or low volume disease noted on sentinel lymph node, I think tangents only is reasonable, and I consider high tangents in select patients who might have other factors, or even low risk macrometastatic disease, given like a 3 millimeter focus, which is very low. In higher risk, higher volume disease on sentinel lymph node, then I sometimes consider regional nodal radiation, including the axilla, not trying to be Halstedian, but I think it's important to have this conversation with patients. And similarly, based on the MA20 and EORTC trials that showed improvements in breast cancer outcomes in patients who have nodal disease, even on an axillary node dissection, I think it's important to discuss these issues with the patients. And thank you very much for your attention.